Okay.
Okay. Now it's 5 o'clock. Now we start our mini symposium. Okay. My dear colleague, I'm Dr. Lu from Taipei Veteran General Hospital. Today we are honored and we are happy to have two Singapore doctors to share with us their experience in handling the endoscopy suite and motility examination in Singapore during the COVID pandemic. So we have Professor Kevin Guo. He is currently the director of endoscopic center in National Singapore Hospital, and Professor Kevin Shea, also from the National Singapore Hospital. And in Taiwan, we have Professor Chen Jianning, Professor Zheng Pinghui, and Dr. Wang Yanbo to host this mini symposium. So in Taiwan, we all know we recently encountered a very severe outbreak of COVID infection in recent 2 weeks. And I asked many questions to Professor Kevin Shen, and he shared his experience with me. So he also proposed he can share with all the physicians his experience in Singapore for all the physicians in Taiwan. So this create this mini symposium. We should thank Professor Guo and Professor Xie for their kindness to share their experience. Now let's start our mini symposium now, and hand over the hosting to Professor Zheng. Professor Zheng, please.
Thank you, Professor Lu. Dear guest, this is Dr. Zheng from National Taiwan University Hospital. It's my greatest honor and pleasure to host the first session. We are focused on the management in the service of GI endoscopy and the motility examinations during the COVID-19 outbreak. This is what we need most. We need the expert experience from Singapore. Then I will introduce the first speaker. This Dr. Ko Jiang-yi, who graduated from National University of Singapore. He is an expert in all the endoscopy procedures, including the gastric cancer, colon cancer, general endoscopy, and the ERCP US. Currently, he is the consultant of the National University Cancer Institute. He is also the assistant professor of the Department of Medicine, Yung Long Lin School of Medicine. As Professor Lu has just said, the Professor Ko, he is currently serves as the director of the endoscopy center at National University Hospital, Singapore. So we are more than happy to have him to share his valuable experience with us. Professor Ko, please.
Thank you. Can you see my screen? Let me see.
Okay.
Yes, we can see.
Let me just play. While waiting for the slides to set up, can you see the PowerPoint? Is it playing?
Yes.
Sorry, there's some problem with my subtitles. But maybe I can just give me 1 second. Yeah, so thank you for the kind introduction. I think when no one has all the answers for this pandemic, and I just hope to just share some of our experience, and I think we can have a good discussion to see what's best, because what works for us may not necessarily work for everybody. And it's just an example of what we do. And the other thing with this pandemic, we realized that there are a lot of centers that do things quite differently. And so I think if we can share and learn from each other, I think that will be something that we all can benefit. Okay, so I think, as you know, Singapore generally has had a good run in holding off the pandemic. That said, the mainstay of our local transmission is to reduce social spread in the community. And so this is done by two means. One is a lot of restrictions. You can see recently we have entered another round of restrictions where we have restrictions on dining in. There's no restaurants, all cannot serve customers at dining in. They can only take away. The cinemas, church, temples, religious services are all closed. Only 50 people. Weddings and funerals also a very small numbers can attend. And right now the group restriction, meaning if you go out as a group, you can only go out as a group of 2. Yeah, which is big trouble for me. My family is 5, so it's very hard on many people, but it's necessary, I guess, to break the transmission in community spread. So I'll just bring you through some of the what we have in our endo center. So we have registration, we have triage. This is our procedure, one of our procedure rooms. This is our recovery bay. So we are not a very big endoscopy center. Currently, we have 6 physical rooms and 1 room remotely. We do on average about 15,000 procedures a year. And when this COVID first hit us last year, we had 3 main considerations when we wanted to implement some of the measures. First, we wanted to prevent, of course, transmission in endoscopy center. Secondly, we wanted to preserve capacity. We don't want to have a center that has no COVID transmission, but not doing any cases, because that would not really help the overall mission. And the third thing we wanted to do is ensure sustainability, because when we first started some of these measures in end of February last year, we were thinking that it will only be a few months and then we'll be okay. But we realized that actually the pandemic is still on, even more than a year and a half on. And so we have to really think about staff fatigue and some of these things that we do. While we want to keep the pandemic going, we also want to make sure that our staff are not tired out by measures that are not sustainable long term. So we, as far as possible, we try to do things that are sensible. Yeah, so this is our Ministry of Health's guidance on PPE use, what sort of PPE to use. So you can see most of the time we have really the 3 at the bottom: the mask, the gown, gloves, and the goggles in endoscopy center. And for COVID suspect patients, we have this additional positive air pressure respirator, the PPAR. So this will be something that we do for COVID suspect patients. But I must emphasize that we try not to do endoscopy on them because of the chance of it aerosolizing. Yeah, and this is so in summary, this is the PPE use in our current state. This is again something in flux, because depending on the chance of community spread, like for example, recently up to recently, we were wearing surgical masks for most of the regular patients, but due to recent transmissions in hospitals, we have moved to N95 for all patient-facing activities. And we were fortunate also to review some of the major societies' guidelines. And so we have a reference article if you could have a look, but I will refer to it briefly in some of these measures. So when we talk about COVID-19 endoscopy center measures, they can be divided generally into a few groups. One is staff measures. Second is patient measures, whether we talk about pre-endoscopy, endoscopy, and post-endoscopy, whether we give them a surveillance call. So let me just go through these measures in a bit more detail, and then we can open for discussion. So pre-endoscopy, this is the different guidelines with the US Joint GI Society, AGA, ASGE, Canadian Association of Gastroenterology, ESGE, United Kingdom, Australia, and Asia. However, do note that many of these guidelines were provided very early on in the pandemic, because everybody wanted to have some say, to have some statement and guidance when people were very early on. now we are almost a year on some of these guidelines, and the information we have available is also different from when many of these societies put their guidelines. So we have to take these guidelines with a pinch of salt, because what was applicable then may now seem a little bit foolhardy. But that's it. Generally, the principles, I think, are similar. I don't think many of these things would change. So in terms of procedures, scheduling, you can see pre-endoscopy, most societies will want to review their procedures and do the more urgent ones. The screening and the not so urgent ones, they may want to defer. Secondly, when we talk about patient pre-screening, many people would check with the patients before they turn up in the hospital, because you don't want the patient, especially in Taiwan, where sometimes the patients live far away from hospital. If they may drive, for example, or take 2-3 hours to get to the hospital, only to be told, oh, you cannot do the procedure. So it would be prudent to definitely check with the patient before. And in our center, we actually check them with them a few days before. So going on to the pre-endoscopy measures, we do review our cases, for example, screening cases. Initially, when we first started last year, we actually deferred all screening cases. That means if you are here for colonoscopy screening, you will say, don't come. We'll just reschedule your case 3 months on and all that. But later, this time around, when I asked my boss, he was saying, basically, the ministry stand is a bit different now, because they are thinking this may be medium to long term. So they're thinking that if it's not, if there's some symptoms, there's any risk factors or that, to just please carry on, rather than to defer for too long, because otherwise some of these patients will suffer. Even screening colonoscopes, because the whole idea of screening is to pick up cancer. And so if you don't pick up the cancer, you cannot treat the cancer. And so I think this is something that we have kind of been nuanced through the years. So we have to kind of be careful. So we will say, yes, we defer non-urgent procedures, but how aggressively we defer will depend on the situation. I think generally cases that have been postponed for a few months already should be prioritized, because then you don't want to keep the patient unscoped for very long. Secondly, when we talk about screening of patients, in our endo center, we do call them 2 days before to confirm that the patient is firstly still coming for the procedure. This will also allow them enough time, if they, for example, to get the bowel prep, and also we also check at the same time patient symptoms. If they have fever, if they have flu symptoms, we tell them we will reschedule the procedure. At the same time, when they come to hospital, there's another round of screening. Our hospital is now like an army camp. There's a lot of guard houses, and so to get past the guard house, they have to take your temperature. They have to check. They will ask you more questions, and so anybody that comes to our endoscopy center already would have passed all these checks. So hopefully this will reduce any patients with symptoms and COVID turning up in the first place. In addition, to reduce ancillary spread to the caregivers, only one patient can accompany the patient right now. So only one caregiver can accompany the patient. And in the waiting area, we space out our chairs and our waiting area 1 meter apart. So this is a big stress to our system, because already we have a lot of space constraint. So we have sometimes our waiting area spills out to the corridor outside, but still within the hospital, fortunately. The other thing is that we have a special isolation room or area for patients with symptoms. In case somebody turns up and somehow they said no to everything, but when they come to see us, they have a fever, we will put them in a separate room that they will not be in contact with anybody else. So this is something that we want to, we have set aside, and the hospital makes us comply. And then once we do that, we will be able to test the patient for COVID and also send him for appropriate care. So when we talk about endoscopy measures, I think the key point is location of scope. So any patient that's suspected to have COVID, you want to defer the patient until we can confirm that there is no COVID. So this is the main point. For example, if the patient has COVID and patient has bleeding but not severe bleeding, we would test the patient, make sure the COVID is negative, and then we would institute measures then we can scope the patient safely in endoscopy center. However, if we know that the patient is positive, we will not scope the patient in endoscopy center, because then you will potentially spread COVID to the rest of the endoscopy center. What we will do is we will either scope the patient in an operating theater. We have one dedicated operating theater that can take COVID patients. So we will bring the patient there, and we will scope the patient there. Or if the patient is very sick and, for example, intubated in ICU, I did an ICU case last year. So then the patient is already in ICU. We will bring the scope and the team to ICU to scope, rather than risk spreading the COVID all around the hospital by patient movement, as well as by staff movement as well, because you expose your patient and your patients and your staff unnecessarily. Yeah. So the third point is that we only do emergency scopes. I think so far the scopes we've done in COVID positive patients are bleeding, as well as airway emergencies. We had a respiratory doctor who did a bronchoscopy to take out a foreign body. So these are airway emergencies that we have no choice. Yeah. And then of course, when we talk about members of the team, if we do a COVID scope, we will minimize the total number of staff going in. So usually in endoscopy, we may have up to 4 staff going in, the endoscopist, the endoscopy assistant, usually the trainee doctor, and then maybe the assistant nurses, 1 or sometimes 2 nurses. But in COVID-19 patient scopes, we limit it only to the endoscopist, and then the nurse will double up as the assistant, or basically we limit additional exposure. No trainees to be involved in endoscopy, COVID positive cases. Yeah. So this is the summary table from the different societies. I think generally the societies differ in the PPE recommendations, and this is partly also because of availability. At that time, I think many of these were in the March, April, and the COVID, and the PPE was not widely available, even in societies that wanted them. Also, just a word about staff measures. So the government, our government suggests a split team approach. That means they have, for example, 2 teams, Team A and Team B, on rotating shifts. This is to reduce the overall contact of any patient to the whole endoscopy, to the whole to the COVID patient. So for example, if there's a COVID exposure, maybe only half the team will be affected. But however, in practically, this is not very practical, because many hospitals and many departments are not staffed twice as much as they can need. That means we don't have 2 times the number of staff that we can still run our services rationally. So what we do in endoscopy center is we do a cohorted approach. For example, we have endoscopy rooms, right, 1 to 6. And so, for example, the room 1 nurses, they don't go over to room 2. And the room 2 nurses, they don't go over to room 1. And they stay in their room. And this set of nurses will stay the entire week. And so they change only weekly. And so any exposure potentially will only affect the team in room 1. Yeah, so this is what we have done from that angle. Even their meals, they are supposed to eat only in that room team, with their room team, because meal times are also a risk. When you take off your mask, when you are in healthcare setting in Singapore, you're always wearing a mask, so no problems. But when you eat, you have to take off your mask. So when the nurses in the rooms go for meal breaks, number 1, the whole room goes at the same time, and the meal breaks are supposed to be on the same spot. So we have to find a spot for them to eat that they don't cross over with other teams. So this is difficult because our endoscopy center is not very spacious, but we try our best to kind of do some of these measures. Yeah, so I think I've come to the end of my brief sharing, and I think more important will also be the discussion. I look forward to some of that.
Yeah, thank you, Professor Cole, for your expert sharing. Yeah, maybe we can save the questions later for discussion section.
Yes.
Okay. Yeah, now we will move to the second speaker. Yeah, it's also my greatest honor to introduce our best friend, Professor Kevin Xie. He is the expert in the functional GI disorder. Yeah, he currently running the gastromotility lab and the multidisciplinary IBS clinic in NUHS. Yeah. Professor Kevin Xie, he also served as the Secretary General of the Asian Neurogastroenterology and Motility Association. Last year, during the pandemic, he also initiated a very important project to organize all the experts to to draft the practice of GI motility laboratory, the position statement of the representative of the ANMS. So now we are very more than happy to have Professor Xie to share his valuable experience with us. Professor Xie, please.
声音没有开。We cannot hear you.
Hello?
Okay.
Kevin?
Hi.
Yeah.
Sorry. I just unmute myself. Thank you. So I'd like to thank all the friends here that haven't seen for 2 years. So 谢谢陈教授介绍我。So I'll continue my talk. So just now, Professor Chang's introduced to you that we did have a practice statement regarding what to do for gastromotility lab. So a lot of you would have worked in the gastromotility lab. So besides protecting patients, obviously one of the important things also protecting the staff that work in the lab. Besides our ANMA statements, there's also a European Society Neurogastromotility statement also by Professor Yan Tak team. So these are the two very good guidelines where you can go to get more help. So just to go through some of the statements quickly. So there are 19 statements, one, regular planning assessment. Just now, I think Professor Koh also talked about how you have to plan ahead before, you prepare for COVID. Infection control, you work infection control team, safe handling of GML inventory. All GML staff should undergo training, and standard infection is very important. And all patients should be tried. This is one of the most important things. All elective cases, especially for a lot of the gastromotility labs procedure, there may not be urgent. So you need to think whether you want to postpone the non-urgent case or further to, if let's say, depending on how long COVID-19 will last, nobody will know. So you need to plan ahead also what you can postpone and what you want to do. Low risk patient, depending on the urgent or time sensitive cases, you can defer or cannot defer. Or even for patients who later will have more and more patients who have COVID, but when they recovered, what do you need to do for them? And we also look at different kind of GML procedure. For example, all of them are different. For example, esophageal manometry, pH test, urine breath test, they all are high risk procedure. But nowadays we'll talk about a new study that look at different tests and we have new things. Another thing, besides the esophageal, I know that some of you also do anal rectal stuff. Remember that the virus can also be in your stool. So when we talk about GML stool, GML procedures, there will be your core procedures, your specialized diagnostic tests, and your specialized therapeutic tests, as well as research-based procedures. And all of them are different. We differentiate them into high risk and low risk. For some of the low risk stuff would be your wireless motility capsule or your chronic transit marker study. Those are low risk. Or we'll still consider the rest as high risk because of the risk of aerolization. The European try to look at this in different ways also according to the risk of the procedure as well as the risk of transmissions from the patient point of view to the healthcare professional, whether it's from healthcare professional to the patient or from the patient to the healthcare professional. If both are low risk, obviously you can perform tests according to low risk estimate. But when it comes to moderate risk, then you have to decide whether right now, whether your center will provide, for example, patient with a swab. I know that there are some centers who would do the swab first before they allow the patient to go on and do the risk. So it depends on what is your hospital guidelines and whether it's available or not. So in our hospital, we have to get swab nowadays. If you have vaccinated, for example, like myself, then I'll need to be swabbed, nasopharyngeal swab twice. Every 2 weeks. So we'll get swabbed every 2 weeks. But if you are not vaccinated, then it's once every week for healthcare workers. So all of the people in the hospital will need to get swabbed for COVID. And depending on whether the patient's COVID status is known or not, then you can decide whether these procedures you should go ahead or don't get. But for high risk patients with low risk procedure, then you can, most of the time you'll decide to postpone. So you have to talk to your case. Not every case will be the same, but it should be decided within a team. Again, the 11th is when you decide to have the patient in your ward. I think this is quite similar to what Professor Koh talked about when the patient before the patient come into the GML lab, similar to endoscopy center, you need to check, call them before to check whether they have problem, when they actually have any signs of COVID-19, check with them. When they come in, we still make sure there's no environmental decontamination, make sure that they are sitting 1 meter apart, and all non-disposable and non-dedicated GML equipment should be disinfected. So you must remember some of the machine, for example, the breath test machine, if the machine is exposed to COVID-19, depending on what machine you use, you may have a problem of you may not be able to use the machine again. So this is something to bear in mind because those are expensive machines. So we say that you should have your own workflow during COVID-19. This is the workflow that we recommended in the ANMA publications. When the patient register what you should do during the procedure time, what we should do, and then how to handle the procedure. I'll be sharing the slides with Professor Lu and Professor Chen. So if any of you are interested in the slides, you can get it from there. And also, how to get the publication also. And just now we were talking about protection gear. This is a minimum protection gear that our GML staff like to wear. But the problem is really 不人道 if you ask them to wear it 24 hours. And if any of you have tried to do a scope wearing a full PPE, after 1 hour, you will know that it's very uncomfortable. So we also try to segregate our staff into two different areas if we can, so that they have a bit of time to rest. If not, they will start to have like masking or like some of my staff will tell me that, doctor, I just cannot wear it. I say, why? Because I'm getting toto. Then like that's like the end. They cannot do anything anymore. They will not wear the protective gear. And also there's standard PPE and full PPE depending on how high the risk, just like what Professor Ko said. But during the DDW this time, we have some good news. They did a study that looked at nasogastric intubation, high risk monitoring, and how dangerous it is, whether it's causing any aerosol generations. So what they did was they look at, for example, the spread of droplets and aerosol and see whether the droplet and aerosol actually spread during the HRM and the 24-hour pH. And they have two groups, and mainly they want to look at, for example, whether this is an aerosol generalizing procedures or whether putting an air purifier in the room helps, it doesn't, and whether the examination actually increased the risk of droplet spreads. So what they did was they put this aerosol generation count to this laser particle counter in the room that can look at the aerosol generations. And good news, study shows that this is very new. New, we just shared with us during the DDW meeting, shows that there was no extra aerosol generations during HRM or the pH2 tube and generation. So we can quite happy. I just shared this with my staff in HRM lab, in the GML lab. They are quite happy to see this. And also during the looking at the droplets, so they use the same count, wearing the apron and use this particle sensor to look at the. You can see on this side, the green dots is the droplets, and then they can calculate it using a software. And I'd like to show you again, we have good news. There's only limited droplets was spread or elicited on the patient, but not on the nurses, not on the technician. So you have this a bit of a droplets on the patient especially when they remove, not just during insertions. The droplets will spread during the removal of the tube itself. So because the tube will dangle, so you be very careful during the tube when it dangles. So that is the chance that when you may get droplets sensation. So beware of that. Another one of the last thing a lot of you also run the urea breath test in your gastromotility lab. I know that I did. So for that, we still consider urea breath test a high risk procedure. Why? Because you cannot go away from creating an aerosol, because the patient do need to blow into the bag for sample collections. So what I must say is, if this is non-urgent, nobody will die from H. pylori the next day normally. Then it should be postponed. But yesterday also said that yes, maybe it can be postponed, but maybe you can don't do it in hospital, but do it at home. So I'm not sure how many of you do it at home. We thought that, this is a good idea. Every time when there is a new situation, even COVID, it's time,从这边变这通, it's time to do research. So we actually did a research. So we want to see, can you actually do home UBT test? So obviously nowadays a lot of us buy food, from there. So we have the good Grab driver carry the UBT back to the hospital after they blow it. But the problem is we found that a lot of patients actually don't know how to blow into the bag. So the key limiting step is actually holding the tube and blow it inside. And a lot of people can't extend the breath. So 吹了过后不能那个气不能够集中. So we actually tried several ways. We did a written instruction. Nobody understand how to do it. We did a video instruction. Nobody how to do it. But in the end, we have to do a sort of a personalized UBT test for the patient.
Like this.
Then
the bag with
we managed to nail it down. So we produced a more personalized, a step by step.
For 5, 4, 3, 2, 1. Oh.
So a step-by-step video. Finally, we nail it down. Then the patients can do urea breath test at home by themselves. So the reason why I want to show you this is because I think a lot of us are going through a very difficult time. You don't know what is going on, but it's also a time that you can think about what can be done through telemedicine. For example, a lot of our hospital is asking a lot of us to look through our cases and maybe arrange for these cases to be done telemedicine wise. But as you know, most of my patients are IBS patients. If they are during this pandemic, a lot of them actually doing very well, so they don't come and see me, which is I'm very glad. But also the time to think about what to improve. So if let's say during this time, you should think about what can be moved from hospital to home, so that so that the patients won't come to the hospital and they won't expose themselves to COVID-19, and also save your staff from exposing themselves to the patient. So I hope that these more explanations help you to
how to perform a urea.
Let us think about what we can do during this difficult time. Thank you very much.
Thank you. Yes, thank you, Kevin. Thank you for sharing with us these very useful tips and update information for including the home UBT. Yeah, very, very useful. Yeah, now maybe we could move to the next section for full discussion. Maybe I'll hand over my job to Dr. Wang Yanbo.
I'm Wang Yanbo from Taipei Veteran General Hospital. Thanks for Professor Ko and Professor Xia's excellent talk and share your experience with us. Next, we'll start from Q&A, and I think the audience and everybody can ask your question about no matter it's about the experience or the real world practice of anything, any ideas about the further management of the endoscopy and the motility lab during the COVID-19. And first, I think I'll start from one question, because both Professor Ko and Professor Xia talk about about screening about the symptomatic patient before doing the endoscope. Anybody who has suspected with the COVID-19 should do the test. However, we know 50% of COVID-19 patients are asymptomatic. So how do you deal with this kind of condition? I think 因为我们说问答的时候可以中文英文都可以，我想我们以或许中文为主，那有些医学名词要用英文的 medical， 我想大部分都医疗人员应该都 OK 啦。对，那我想就是如何去找到这个，如果没症状的我们就当做他没事嘛，因为我们现在其实在台湾现在是开始一个 outbreak， 很多传播都是从无症状的这个感染者在大幅传播的，所以想不知道你们经验在这方面的管控怎么做，谢谢。
坦白讲，我可以先讲。坦白讲，如果没有症状，就是说，就是很难查得出。你讲的就对了。所以，可是现在，因为我们现在那个 community cases， 就是说在那个community 的那个case number 不是说很多，所以大多数的人都是 没有症状，也是没有 COVID。可是我也明白，如果有很多相当普遍在外面，那可能这个方式是不是那么准啊？所以第一个是还是要谨慎哦。所以我们无论如何，一旦有看病人就要穿那个 N95，因为我们不知道哪一个人会有 COVID 所以这个是一个方式了。我们每个人都穿 N95，因为我们也不能100%保证他们没有COVID 就是没有办法
其实我跟Kevin 的意见是一样的。其实如果说你将其他人我一直跟他讲，其实在医院做工是最安全的，因为你将每个人都当作是有患者的话，你就会比较小心。反而是为什么大家很多时候高感染区都是比如说超级市场吃东西还是其他地方，因为大家都比较松弛了，没有这样子。所以说我们在医院的话，第一，你看病人的时候，你一定有戴口罩，现在甚至是 N95 的口罩。所以说你如果说做什么东西的话，比如说他一点点症状，他们就会去隔离去另外一个病房，然后医生就会单独看他们。所以说传染就会这样，传染就会转到最低，而不可以松懈。这就是我们其实我觉得，这个在医院其实还比在外面安全。
那我想接着这个问题，因为刚刚 Professor 谢提到说，那个每个礼拜要做2次这个 COVID test， 像这只有内视镜跟这个 Mortality Lab 的工作人员吗？还是每一个医疗人员都做？第二件事情是因为我们其实现在上班大家都在讲分流分场，等于分组。那这样子的话，会不会随时就是像这1年中有没有因为这样就很多人就被验到有了就没来上班？那不知道你们用的是 PCR 还是这个 Antigen Quick Test， 在这个每个礼拜验2次这个。对，
是 PCR， 我们用的是 PCR，
是，
可是刚刚开始，所以我们可能只是验1、2次而已
这样子是所以是刚开始的，就是
刚刚开始，因为最近我们那个community transmission 就是说比较多，所以他们那个政府这样讲了。
然后是整个医院烧地的阿三做事都要验，是每个人都要验。不只是做医生而已，做补习的而已，是每个人都要验，然后
所以医院整个人每一个人都要验了，每1、2个礼拜就要验1次。
对。
有问题了。
那我想那个原生医院那个吴文杰主任问说，这个做胃镜前的话，像你们是固定做快筛吗？还是要看他是不是住在哪一区？比方说那一区有 outbreak 才做快筛，在这1年中，对，就是那个 PCR test。
现在我们是没有做那个 PCR test。OK， 我们只是因为他们没有症状，我们就表示他们应该可以 proceed 就是做了。可是我们做的时候也是要穿 N95 这样东西。
OK， 是。那像你们这样病人，如果像你判断他可能需要做的话，这个都是在 health insurance cover， 还是说他另外要自己付钱？比方说你怀疑他可能 COVID 今天来做胃镜，他要先检查，这个费用是包括在本来他的医疗费用里面，还是他另外要付这个费用？
现在是两个都是，一个是如果他们有症状，通常他们的那个费用是自己付，可是如果是需要留院就因为政府最近规矩全部要留院的那个病患都一定要有那个 COVID test 所以一旦有政府规矩，那没有办法，他们会付咯，所以这个比较一点复杂可是大多数如果你自己有症状，那个 COVID test 通常是自己付除非有拎去那个 cluster， 如果有好像最近我们有一些那个地区。有好像一些超市百货公司这样有一些COVID， 就是政府规矩，如果你有去过这个地方，就可以去拿那个 swab test，怎么去确认也是很难讲啦。可是他们这样的那个情况，那个 swab test 就是 free 免费。
新加坡做1次要多少钱
我们做相当贵了，因为最也是超过，因为也是 PCR test 嘛，所以差不多200刚刚少过200新币嘞是
差不多4、5千块台币嘛。 4000块，
是更多。
比如说比如说在医院，我们刚才讲说，2个星期做一次的，现在他们也是比较节省钱的方法，就是他们3个人放在一个，就是放一个 tube 里面，就是从以后如果说有的话，他们再从3个里面就再叫3个人再来另外做，所以说这样子的话，你可以减少差不多68%的那个第一批的钱。
那我们有一个卢大夫有问说，就是新加坡有新创公司的 Bristol Nicks 说用这个呼气测口 V 在樟宜机场这样会使用，不知道你们有相关经验吗？是，
我们还没有去
有听说这个新闻，
一年多了，就是说他们要开始试验了，因为这种是好像一种很准的那个 antigen test。可是问题是不是
PCR
不是全用了，不是很widespread 普遍，只是几个地方才有。是刚刚开始，他们要是可能做2个，做那个 breath test， 然后做那个 swab， then 可以看那个准性嘛。
那我想实际上请问一个经验，因为我们现在台湾等于刚开始 outbreak， 那新加坡等于去年暑假的时候一个 outbreak 下来，中间看起来还不错。最近可能又有一点点，想问一下，像你们的这个不管内视镜 motility day， 像是从去年7月到现在就一直 postpone 下去，还是大概去年几月开始恢复正常，好像赶工一样赶了一些病人，然后最近又开始管制这样子？谢谢。
就是比如说像我们这样子那个Europe breath test 有其他 HIM， 其实这些我们都关于是 non-urgent cases， 都是推迟的，然后。过了，我们差不多真正的观点是跟着政府的 circuit break， 我们有一个叫做 circuit breaker， 就是真的是管制的时候，比如说外面的超级市场都是关的，我们电梯也只可以搭4个人这样子，那时候就真的是关。不过我们跟着他们开的话，当那个一开始开的话，我们也是跟着开。其实是现在Professor Cole 也是有 share 那个，就是他们有 phase 1、phase 2、phase 3这样子，就慢慢开够，也不会说会有太多的人，因为讲真的，很多病人其实也决定在那个时候不会来，所以慢慢的就会看到一个有点回潮。
我也想问一个问题，问 Kevin， 就跟彦博问类似的问题，就是说像 Monomogy， 像我们从这个月这次 outbreak 之后，我们全部停掉了，所以我想要知道。你们这个某些类的这个 natural cause 大概从什么时候开始可以 restart？ 像我现在有2-3个 eclampsia 的病人，就这样就整个就 hold 住了，我也不敢做，他也不敢来医院，所以我想要知道就是这个点到底要切到哪里，而且真的要进 negative pressure room 来做吗？
很难首先我们刚刚我们有讲到，其实当他看到比如说 eclampsia， 如果说他要去做，比如说。开刀 POEM 还是什么的话，这样子的话，可能我们就可以跟他讨论，这是个别性的，他们是可能需要有时间差嘛，对不对？因为他如果说开刀做 POEM 的话，就会考虑真的是穿 PPE， 然后帮他做，这就是个别，就是每个看他需不需要早一点做，当然，如果说穿 PPE 的话，不会说每个 case， 比如说像这样子，就要跟那个就是说跟那个内窥镜人讨论。其他的 case 其实通常可以 delay 的，都代表说他们可以蛮推的。我还没有很少，真的是我去年，比如说我们停的时候，我们的医院虽然说我们的也有做 PO， 也没有做其他的，真的是很少有。我还没有很少 case 是需要做的。然后我们讲真的，关了有2个月吧，没有真的是很大的可能是我们的生意也是不是很好吧。因为其他的时候，你关的时候，病人也不会去找其他的医生，就是他们也不会说有很多人在看医生的话，你就比较减少。而且讲另外一个 functional 病人的话，其实在COVID 的时候，他们不喜欢来医院，所以说相对上就减少。不过讲如果真正需要做，真的是需要做 POEM， 真的是要开刀的话，就会穿 PPE 整副来做吧。
所以你们的 lab 恢复正常了吗？
现在之前恢复正常了，现在还是正常，要看每一天政府换，比如说刚才我们看到 phase 1、phase 2，只要政府讲说不可以，然后医院讲 全部其实现在全部 non-essential by right 都应该停止。可是像你讲的这样子，停止太久的话，又会有反回流的话，我们现在还是有在做，尤其是现在看到那个最近那个HRM 跟那个 PS 的话，我会比较放心一点。
对，这个资料很好。
对对对，吹的还是很难哦，吹的根本就是
就吹出来
了，就吹出来了。
我想请教一个问题，请教那个 Kevin 哈，Kevin 还是 Kevin 哈，就是你们真的有在落实那个你刚才讲那个 rotation 的 staff 有正在分汤嘛？就是医生有分2个组还是怎么样嘛？
我们原本起初好像去年4月的时候有一些分组了，可是不是那么好像现实，因为我们不是说很多医生好像可以好像不去做工啊，不去上班，也是很多那个 wards 啦门诊啊也看不到，所以我们只是顺着那个 cohorting， 就是说这个位置的那个医生不会动了，可是只是靠这个位置，我们大多数是这样啊，就是说看门诊的有一些，甚至有一些只是看门诊的，有些部门啊，他们只是看门诊的，就是看门诊，不去那个病房，但去看病房的不去门诊，就是这样。有些人是这样啦，可是我们消化科比较难，因为我们有门诊有病房，也是有内窥镜中心，所以比较复杂啊。可是这个是一个方式啦。那个政府当然是讲，如果做工开工的，他们只可以分成一半来做，一半不做。现在我们政府讲，全部可以从家里做就家里做，不要全部都不要来上班。可是那个也是看那个工作是怎么样的工作啊。
其实
在内视镜中心里面人有分一半在家休息，一半在家一半在
我们医生大多数是没有了，护士也是没有了。
technician 啦 ，staff 啦
，technician。
都上班。
我的 technician 其实我有两个 general technician， 他们是有在不同的房间，一人做一个，分开哦。不过还是不能够让他们在家，他们在家的话，可能我要去做。
那我想庄教授有问一个问题，说新加坡有考虑用这个口水 saliva 的这个 PCR 取代 swab 吗？有这个计划吗？
我是不是那个专科啦？可是我听他们讲那个 saliva， 因为问题是那个 COVID 就是一个感冒的那个病毒啊，
是，
所以那个 saliva 那个
准确率不高，
不是说很好，因为 saliva 很多其他病菌啊，所以要查出是不是那么准。
那想，因为都是消化科的，这个不能用 sonography 腹部超音波也是这样穿全套吗？还是就简单手套？还是说干脆不做 sonography， 让他去做 CT scan 了？我在新加坡。
坦白讲，我们这边方面，我们很少自己做那个超声波，除非是 EUS 我们还做。
OK， 是。
其实刚才你讲到那个，比如说那个口水啊什么的，甚至是讲很多我们看到的，其实如果说那个nasopharyngeal做的不对的话，其实那个抽到率也是很差。很多人其实你看到他们这样子插上去，对不对？是错的。很多的照片你看到都是很可怕的，就是他们的姿势要对。可惜其实很多人做错，拿到只是可能是鼻炎是什么而已。所以说这个 training 是很重要的。
我有个问题啊，因为就是刚才那个 Kevin 有提到，就是 trainee 的话就是尽量少嘛，还甚至写好像有 no trainee， 那会不会影响到？因为我们现在也碰到类似的问题了，那会不会影响到这个 trainee 的训练，然后如何补救呢？
我先讲一句，其实Dr. Kelvin 有发表在这一方面的publication， 他对这一方面是非常有兴趣的，就是在这个时候怎么样的 training， 怎样的 scope 帮他推销一下。
所以我一个那个 paper 会发送，就是说几个东西，一个是当然如果很普通的很 basic 的那个 training， 很基本的那个训练。第一个可以用 model 去开始，如果是刚刚开始那个消化科trainee，就是说可以用一些 model 来做示范 不需要病人嘛，起初开始的时候了，因为这个也是可以锻炼他们那个内窥镜那个 scope 的那个姿势，也是帮助他们，也是第一个了。第二个就是说，我们可能以前我们是看那个做的那个号码有做多少啊，就来训练。可能我们这个如果是长久啊，可能要考虑看那个 competency， 就是说不是只是看那个次数，是看能不能做。好像比如说要拿那个polyp， 要割出那个 polyp， 就是说割出那个大肠那个息肉就是说可以割还是不可以不割，不算是你有做多少个大肠镜啊这样来算，因为现在我们还是很那个旧的方式，就是说我们一直看那个次数你做200个那个大肠或者300个大肠就算是可以成功的那个训练，可是可能我们要一去看那个 competency， 就是说那个你能不能做那个能不能做那个polyp removal 还是怎么样？这个可能所以那个次数可能不是说那么重要，可是那个技术还是会保持，这个是一个 suggestion 一个方式可是这个是整体很多人都有这种问题。
那我想在最后问一个问题，就是有关这个隔离的问题，就是万一有 staff positive 的话，因为我们都已经穿这 PPE 嘛，都是穿 N95， 那万一你做的病人隔几天发现 COVID-19， 以新加坡的政策是你还是要被隔离吗？还是你当初有穿好隔离衣，你就不用被这个隔离？想问一下你们的 policy， 谢谢。
这个是看他们如果真的有 COVID 的 case， 他们会看你看他的时候有没有穿全部的 PPE， 如果有穿全部的 PPE， 就是讲 OK， 应该是没有大问题，也是要自己要看那个症状啦，还是这样，因为好像现在我们是有那个 app， 就是那个手机那个 Trace Together app， 就是说如果你很靠近一个有 COVID 的人，他们会跟你讲你有好像上个礼拜有靠近一个 COVID 的人。可是他们不讲你要自己隔离，他们讲你可能要关注自己的那个体温症状这样如果有问题的人要去看病，除非是好像就是他们讲是 close contact， 就是说你的同事那个同事可能没有办法要有那个 quarantine order， 就是要有留在家里或者去那个 quarantine facility 留2个礼拜3个礼拜这样。可是如果因为我们是有穿 PPE， 所以大多数的人都是不需要quarantine的。相反讲，我们有一个上次去年我们有一个 registrar， 就是说那个 trainee， 他有去看一个病患，可是他们有穿全部的 PPE， 可是没有戴那个眼镜就是他们讲那个不可以，就是他有两个礼拜在家里所以这个是讲是 universal precaution， 是因为我们不知道哪一个人会有 COVID， 就是没有办法，可能要比较谨慎，那个 PPE 要谨慎了一点才能继续做工不然
就是再补充一点之前的时候就是有一间医院，他们刚开始预测到有一个其中一个其实还是帮人家 swab 的一个护士有那个COVID-19 的时候，其实整个区整个 ward 的全部人都要去quarantine 的，其实这是避无可避的。其实就是说，比如说我今天如果说在做 round， 然后发现到其实有人真的是有几个 COVID case 的话，真的是整个区有经过里面的人都要去 quarantine 其实我们的都有这个准备。然后关于刚才讲到很多就是在这段时间有没有分组什么？我想跟你们讲是，其实在那个 COVID-19 真的是lockdown 的时候，其实可以蛮寂寞的。然后其实我们都不，你都不，其实不鼓励去见对方医生或者是什么，其实你就是做你的工，去你的 clinic， 你就回家，你不要去就是串门子还是什么的，这个讲嗨什么然后大家都是 hello 这样子，就是这真的是有时候你去年我就觉得自己好像自己在做私人的诊所，都没有看到人了，其实。
我再问一个问题最后一个， 就是说，像如果有比较长，可能给 Professor Cole，就是说，如果有那种比较长的 endoscopy procedure，像 ESD 之类的，真的是要穿着，我是帮人家问的，如果全套的 PPE 这样子做个2-3个小时，那个眼镜不是全部盲雾的吗？
那个比较难你讲的对，可是要看那个眼镜，因为眼镜坦白讲不是全部 occlusive， 就是说不是全部完全盖住，还有一点透所以是最主要是因为那个 splash 就是没有好像进那个眼球这样了，因为我们这普通的眼镜也是有一点保护了，可是旁边还可以进嘛，所以那个眼镜那个意思不是讲不是完全，如果不完全那个盖住就比较少那个 fog， 就是那个昏迷
雾气
对对对，可是有些比较紧的啦就比较难了，因为你那个 mask 那个透露就有一点透就很难没有办法，我们现在全部是这样
那我跟大家分享，因为我今天才刚带全套 PPE， 刚做个 ESD， 做了3个多小时，我就是没有做戴 N95， 我就戴 double mask， 戴双层面罩，真的很累。所以，但就是你会努力的深呼吸，或许这样可以瘦一点，说不定。那我刚刚那个 Professor Cole 有分享他这个 endoscope training 的这个 paper 在 JGH 给大家分享，大家可以点下来下载，可以看看。因为我想我们接下来正好要换年度了啦，又有新一步的 training 进来，可能他们的受训，我想前半年就算我们开放了，病人大概也不愿意来。整个 training 量都会下降，我想大家可以做一个参考。那不知道各位如果没有什么问题，我想最后交给陈建林陈主任，最后帮我们做一个 closing。是。
我想我讲中文，反正我没有什么 medical term 嘛，我就大家都听得懂。那今天很感谢Professor 夏还有 Professor Cole， 他对我们分享一下在 COVID 疫情之下胃肠蠕动检查以内视镜检查的管理，还有如何去监控它的品质我相信我们不是愿意得到这个病，也不愿意遇到这种情况，但是我们已经遇到，我们就要面对这样的一个情况。那我们现在台湾也是突然这2个礼拜，像卢教授讲，这2个礼拜 outbreak 跑出来变得很严重那我相信我们应该都会面对某些程度的风险。所以我们今天学到很多东西那我们知道说在这样的一个风险之下，我们要保护自己，要保护我们的病人那也很感谢卢教授跟胃肠蠕动协会 organize 这样一个 meeting， 让我们大家能够参与这样一个活动，那也学了不少那我们相信将来也许我们疫情控制得很好的时候，我们可以在某个地方大家都在一起开会那今天也很高兴能够跟大家这样情况之下见面那我相信我们将来一定会见得到面谢谢大家。那我们今天会就开到这里OK。Thank you everyone。
最后我再讲一句话，那今天这个平台的建立是我们那个元佑公司 Olympus 帮我们建立了，我们也非常谢谢那个元佑 Olympus 公司，谢谢。
OK，
谢谢。
谢谢。
好，那这。